thank the Pan American for inviting me to talk about the management of renal trauma. I'm going to touch on the diagnosis, treatment, and follow-up of renal injuries in the modern era. To put it in perspective, in the U.S., about 1 to 5% of all traumas involve the genitourinary system. And if you look at abdominal injuries alone, about 10% of those involve the GU system. Of all GU injuries, half of them involve the kidneys. When you look at blunt injuries, there are frequently associated injuries, and about half of all injuries that involve the kidney, you'll also find other abdominal injuries as well. That number goes up in penetrating trauma to 80%. The injuries follow both blunt and penetrating trauma, and in blunt trauma it can occur from a direct blow, like in an assault or in an injury from a sporting event, or can occur from a car accident through acceleration and deceleration mechanism. Penetrating wounds occur from both stabs, gunshot wounds, as well as shotgun wounds. Which patients require screening? Well, it's anyone who has must have first a mechanism of injury that could have produced the trauma. And you must also have signs and symptoms of the injury. These patients also present either hemodynamically stable or unstable. But the hallmark of renal injury is hematuria. So in general, in the stable patient, radiographic evaluation is necessary in penetrating trauma with any degree of hematuria, and in blunt trauma with any degree of gross hematuria or hematuria at microscopic level that's associated with other injuries or has a history of hypotension. The test of choice, as has been described by Dr. Feliciano, is now a CT scan. And the CT scan is the test of choice in the hemodynamically stable patient. It allows us to stage the injury and define the depth and extent of the lacerations that we might see. And it also gives us information about the function of the contralateral kidney. We can see extravasated contrast that might mean injury to the collecting system or might mean active hemorrhage. And we can also see kidney parenchyma that has been devitalized. In addition to that, we can find those other injuries that might be there, like the injuries to the liver or to the spleen. The other diagnostic tests that may be useful in renal trauma include an intravenous pyelogram. This used to be a standard test to diagnose renal injury, but has been replaced by CT. But it can be used if CT is unavailable in your particular area. Ultrasound is another test that is able to give us some information about the state of the kidney. Mostly it's able to highlight major lesions or retroperitoneal hematoma. Unfortunately, it has a fairly low predictive value and a low sensitivity. In an attempt to improve the sensitivity of ultrasound, some centers have begun to use contrast enhancement. And as you can see from this slide, the sensitivity has increased dramatically, but it's still well below the sensitivity of CT scan. But this may be useful in places where CT scan is not available. MRI is another modality that can outline renal injuries. It's able to grade the injuries as equivalently to CT scan, but it's most useful in demonstrating the size of the perirenal hematoma. And it is able to differentiate older from more recent hemorrhage around the kidney. It's most useful in patients who have iodine allergies or who have equivocal findings on CT scan. Now, as I mentioned, grading is important in renal injury, and the grading system that we all utilize is the one developed by the American Association for the Surgery of Trauma in 1989. It was developed through a consensus and expert opinion and has now been prospectively validated and found to correlate directly with the need for surgical intervention. The last 2 decades, we've really moved in renal trauma to a non-operative management, and our AAST grades 1 through 3 are generally, in both blunt and penetrating trauma, able to be managed in this non-operative management. Here is the grading scale, and it goes from minor grade 1 contusions to the more severe injuries of grade 4 that usually involve the collecting system and may involve the main hilum of the kidney, to grade 5, which is shattered kidney or completely devascularized kidney. Now, luckily, the distribution of injuries is most significantly involving the minor injuries. So AAST grades 1 is much more common than a grade 5 injury. And these are the results of 3 studies that have been published of renal injuries. The one is a single center study from University of California, San Francisco, that has a significant experience with the management of renal trauma. And then the one in green is from a national trauma database study that looked at several thousand patients with renal injuries from throughout the United States. And the last one is the most recent study that came from a single center in Dallas, Texas, looking at their experience. And you can see all 3 studies demonstrate the majority of injuries that we see are grades 1 and 2, with very few injuries in the 4 and 5, or the ones that will require or might require operative intervention. These are the same groups looking at the percentage of injuries that were explored by grade, and you can see that, again, grades 1 and 2 infrequently require exploration. Grades 3 also infrequently require exploration, except in the UCSF study. And this may be because this study spanned about a 20-year period, and our management of these injuries has changed throughout that period. So that most of the studies demonstrate that only the grades 4 and 5 actually require operative intervention. And what is the operative intervention that occurs? Mostly in grade 5, these patients are going to come to nephrectomies. You can see that almost 90% of those patients that get operated on who have a grade 5 injury undergo nephrectomy. And of the ones that are operated on that are grade 4, almost 40% of those also undergo nephrectomy. So that is a frequent procedure. Ultra-conservative management suggests that non-operative management is very important in saving renal units. No matter what the intent is, if a patient ends up in the operating room who has a renal injury and it gets explored, they're 64% more likely to undergo a nephrectomy no matter what. So surgical exploration is reserved for the patient who is hemodynamically unstable or can't be stabilized with a couple of units of red cells transfused, who has evidence of collecting system or ureter injury, or who has that grade 5 injury in which 90% are going to require a nephrectomy. So if you're in the operating room, which of these kidneys would you end up exploring if you end up in the operating room for other injuries? Well, the ones that might be associated with renal hemorrhage in a hemodynamically unstable patient, someone who has a pulsatile or expanding perirenal hematoma that you see in the operating room, or someone who has persistent bleeding and a suspected injury to the pelvis or the ureter. But we are able to manage some patients with grade 4 injuries and urine leaks or renal pelvic injuries non-operatively. This is the case of a 25-year-old man who was involved in a motorbike accident. He arrived hemodynamically stable, had a large bruise on his right flank, presumably from striking his side with the handlebars of the motorbike. and underwent a CT scan. You can see a large perinephric hematoma that extends to the hilum, and a small thrombus is located in the renal vein. You can see there. Now, after the CT was performed, a plain X-ray was done, and you can see here there's residual contrast around the renal pelvis, around the collecting system, demonstrating the extravasation of urine that is occurring. The patient then underwent follow-up with a retrograde pyelogram that confirmed the findings of a leak, and then that was followed by placement of a double J stent to drain the injury, and this patient was able to be managed non-operatively despite this very proximal urine leak. So urine extravasation is no longer a definitive indication for surgical exploration. This study from this year showed the experience of one trauma center managing high-grade renal trauma. Patients with urinary extravasation were treated with observation or stent placement, and they used the indications for placement of a stent as pain that was a result of a clot in the ureter, hyperthermia not related to a pulmonary cause, and persistent urine leak as the indications for placement of stents. 37% of their patients were managed with the urine leak required placement of a double J stent, and only 15% of patients required surgical exploration for treatment of a persistent urine leak. Overall, 92% were able to be managed what they called conservatively, which would include endoscopic management, and 80% were managed completely non-operatively. So urinary extravasation did not predict the need for surgical intervention. What did correlate with surgical intervention was if there was a large segment of devascularized renal parenchyma. So if there was greater than 25% renal parenchymal devascularization, these patients more likely required surgical intervention. Well, what about the use of angioembolization? There seemed to be a lack of evidence-based criteria. This is a national trauma database study that involved 9,000 renal injuries. Of those, 1.8% of those patients underwent angioembolization. And the results of the angioembolization were as follows. Grade 3 injuries underwent angioembolization at 16%. Most of the angioembolizations occurred in the grade 4 and 5 injuries, and that occurred at about 62%. The mortality of the group undergoing embolization was about 7.8%, but the failure rate was quite high, with 88% of those patients requiring a secondary procedure. A third underwent a repeat embolization, and about 25% went on to require nephrectomy. 8% had some less invasive procedure like a percutaneous nephrostomy tube or a retrograde urethrogram performed. So 100% of the patients failed the first angioembolization in grades 4 and 5, and failure was 3 times as likely in patients who were injured by penetrating mechanisms. What about follow-up imaging? Which of these patients with the high-grade injuries do we need to have repeat imaging on? Well, basically, patients who have grade 3 lacerations and are hemodynamically stable and don't show any evidence of devitalized fragments really don't require further imaging. Delayed or secondary hemorrhage can occur within 2 days to up to 30 days after the injury, with the formation of pseudoaneurysms and AV fistulas. Grade 4 injuries are recommended to have follow-up within 24 to 72 hours to reevaluate the extravasation from the collecting system. We know that, as I mentioned before, about 80 to 90% of these patients are going to be able to be managed without further follow-up. Repeat imaging is also recommended for patients who develop symptoms like unexplained fever, flank pain or mass, or bleeding. And all patients, no matter how they're managed with grade 4 injuries, should have some assessment of their renal function within their follow-up, and that's best done with radionuclide scintigraphy. The complications that can occur following non-operative management of renal injuries include infected urinoma, a perinephric abscess, persistent urine leak, delayed bleeding, as I mentioned, which can occur in up to 25% of those patients, pseudoaneurysms, and long-term hypertension from renal artery thrombosis or from parenchymal compression. And we all worry about loss of renal function that can occur in patients. It's recognized that in patients who undergo angioembolization, they may lose as much as 10 to 50% of their renal function. So to summarize, the current trend highly favors non-operative management of renal injury. Non-operative management of high-grade renal injury is associated frequently with complications, but most of these complications are able to be managed without surgical intervention. The indications for angioembolization at this time are still ill-defined, but in general should be reserved for high-grade injuries and may require they may require minimal surgical interventions or maximal surgical interventions with nephrectomy. I thank you for your attention and the privilege to present. Thank you.